Okay, good afternoon, everyone, and thanks for joining this Recovery Collaborators meeting. And in particular, thanks for joining if you've not attended one of these before. We know that there are quite a few new people starting to work on the trial before this winter. My name's Leon Peter. I'm an infectious diseases doctor working at the Central Coordinating Office in Oxford, and I'm going to talk through the meeting today. I'll get started because there's quite a few bits to update people about, and also it would be good to leave some time for questions at the end. So the agenda is as here. First of all, because it's been a while since the last meeting, those of you that have been working on the trial for some time will know that the final COVID comparisons closed earlier this year in spring. And actually, this is the first meeting since those comparisons closed. So I'll present the results for those for the sotrovimab and the high-dose dexamethasone comparison. And then I'll move on to the future plans and the current comparisons, which are for influenza and community-acquired pneumonia. Then I'll talk a bit about general trial procedures, and then we'll have a bit of time for question and answer at the end. And some previous meetings we've had obstetric and paediatric updates on the separate days, but just to let people know that there's no separate obstetric or paediatric update with these meetings. And then if you have any questions, please do feel free to enter them into the Q&A as we go along. There may be somebody that answers your question directly to you in the chat if relevant. But if the question is of sort of wider relevance, or we get the same question from several people, we'll probably just answer to the whole group after I've finished talking. For those of you that don't know the trial very well, we've got lots of information on the website, so I please suggest that you have a look there if you're not familiar with the procedures, because there'll be a lot of information, including these slides, and also extra information about the treatment comparisons and sampling and things like that, and all previous results. Next, I'm going to talk more briefly about the final results for the higher dose dexamethasone comparison in patients hospitalised who are requiring ventilatory support. I'll talk about these briefly, partly because the preprint was put up on medRxiv last month, and so you can see the results in detail if you want to go and look at those. And also because the results from some of this population, you'll be aware, have previously been published. So for context, this is the higher dose dexamethasone comparison, which was comparing 20 milligrams of dexamethasone daily, at least initially, versus the usual 6 milligrams of dexamethasone daily in patients admitted with COVID who were hypoxic. Now, this started in 2021, but the randomization of patients not needing ventilatory support, by which we include high-flow nasal oxygen, non-invasive ventilation, and invasive ventilation. So patients that were hypoxic but didn't require those things, the comparison was actually stopped in May 2022 for those patients because of a signal of harm that was identified by the Data Monitoring Committee. And for those patients, we've published the results already, and the Kaplan-Meier for those is shown on the right here. You can see that there was a 60% excess mortality in patients receiving the higher doses of steroids. But at the same time as the DMC recommended stopping the treatment comparison in those patients, they also encouraged continuing it in patients who did require ventilatory support. And so those are the results that I'm going to show now. And this comparison ended at the same time as the sotrovimab comparison on the 31st of March, when funding for the COVID comparisons ended. So this shows the trial profile. 1,749 patients randomized in total to this comparison, but nearly 1,300 of those were those not receiving ventilatory support, for whom we've already reported the results. And that leaves 477 patients who were on NIV or invasive ventilation, who we're reporting here. And about 90% of those were on non-invasive ventilation. And these are the results from that comparison. So you can see 28-day mortality by treatment allocation shown on the left. There was no evidence of any hazard, but also no convincing evidence of any benefit. The rate ratio was 0.87, but with confidence intervals ranging from 0.64 to 1.18, with a p-value of about 0.4. So no evidence that higher dose dexamethasone reduced mortality in patients requiring ventilatory support, but also no evidence of hazard. And it was in contrast to patients who didn't require ventilatory support. There was also no evidence of a significant effect on secondary or safety outcomes. And so the current evidence doesn't really suggest that using high doses of steroids is beneficial even in critically ill patients. Although again, we're limited slightly by the number of patients, because during this comparison, that the number of people admitted requiring ventilation reduced, markedly. Okay, so now on to the forward-looking part of the meeting, which is the current comparisons and plans for this winter. If you've been to one of these meetings before, you'll recognise this sort of figure of the current COVID comparisons. And actually, although we've moved from looking at treatments for COVID to looking at treatments for flu and pneumonia, that the general sort of core of the trial really hasn't changed very much in terms of eligibility or procedures. So we're still looking at patients hospitalised with a pneumonia syndrome. We still collect the same baseline data largely. And then patients at the moment are eligible for either the flu comparisons or the CAP comparison, depending on what their syndrome is. And these two groups are mutually exclusive, so you can't be eligible for the flu comparisons and the CAP comparison. So patients with community-acquired pneumonia, we've got one comparison open at the moment, which is of 6 milligrams of dexamethasone versus usual care without corticosteroids. And for patients with confirmed flu A or B, we've got 3 treatment comparisons open, which are baloxavir and oseltamivir, both of which are influenza antivirals, and also a steroid comparison for patients with hypoxia. And for these 3 comparisons, if you've got flu, you can be eligible for 1 or 2 or all 3 of these comparisons, and they're all separate. So if you're eligible for all 3, then each separate comparison would be an independent coin toss, and you could be allocated to receive either none, 1, 2, or all 3 of the treatments that you're eligible for. In terms of eligibility, this is just a reminder that the main criteria are very similar as previously. So patients need to be hospitalised with a pneumonia syndrome and then fall into one of the 2 following categories, which is having confirmed influenza A or B. And it's worth noting that patients may have a degree of bacterial co-infection and so may be receiving antibiotics, but provided the investigators think that flu is contributing to lung disease, they're still eligible for this comparison. And then the other category is those with community-acquired pneumonia with planned antibiotic treatment without suspected COVID, flu, PCP or TB. And there's more information about that in the protocol, as well as the pneumonia syndrome definition. And as always, if a patient has any medical history that would put them at risk if they were to participate, then they're ineligible. And also, if the attending clinician believes that a specific trial treatment is indicated or contraindicated for any reason, then again, they would be ineligible for that comparison. And at the last meeting, I gave you an update of our plans to expand into the EU, and that's currently underway and is going very well. So as well as hopefully about 50 UK sites that will be active in the flu or CAP comparisons this winter, we're also currently open in 3 EU countries, but are in the process of opening sites in 6 more countries, aiming for 65 sites in total in the EU. And that's on top of existing sites that have been part of the trial for some time in Nepal, Indonesia, Vietnam, South Africa, and Ghana. So we should have a really good collaboration that can recruit serious numbers to try and produce good evidence to inform practice for flu and for CAP. Okay, moving on to the flu comparisons. This is just the current weekly report for flu hospitalizations in England. And actually, there's not very much to see at the moment because we're just starting the period where surveillance starts. But it does show you the previous year's flu epidemics. And I think the main reason for showing this is just that although flu activity is low at the moment, there are starting to be some flu cases. And actually, it could only be a matter of weeks before flu starts taking off. And for a flu trial, we've got a very brief window when we really need to try and get recruitment done. And that could even be as brief as a couple of months if it's like the flu season from 2 years ago. So for all trial teams, please make sure that you're ready and everything is set up to start recruiting flu patients as soon as possible, because we might not get much warning. I'm going to talk a little bit about oseltamivir because this is the flu comparison where I think there's a lot of uncertainty about randomization. And I just want to kind of update people about why we're looking at this treatment and also what evidence there is to support randomization. So we know that neuraminidase inhibitors like oseltamivir reduce the duration of flu symptoms by about 1 day in early infection. And that's been demonstrated in randomized placebo-controlled trials. And there's some observational evidence that suggests that there may be a benefit in hospitalized patients, but there are other observational studies that haven't found this. And evidence from randomized trials is really lacking. So we know that the kind of observational studies that support oseltamivir use in hospitalized patients are prone to biases that can't be reliably avoided. And in particular, just looking back at our recent experience, there were several treatments for COVID-19 where observational data were used to support treatment, like hydroxychloroquine and convalescent plasma, and that were later found to be of no benefit or even harmful in the case of hydroxychloroquine when randomized trials were done. And in the UK, I think we've got a really good culture of randomizing with as uncertainty. And luckily, in the case of COVID, where there wasn't good evidence to support treatments, lots of people randomized, and then we ended up learning much more about what's effective and what isn't. And so without randomized evidence, the efficacy and even actually the safety of oseltamivir in hospitalized patients is uncertain. And I think that was underlined recently by a meta-analysis that was published in The Lancet in August of antivirals for patients hospitalized with flu. And their interpretation of all the available data was that in hospitalized patients with severe flu, oseltamivir and peramivir might reduce duration of hospitalization compared to standard of care or placebo, but the certainty of evidence is low. The effects of all antivirals on mortality and other important patient outcomes are very uncertain due to scarce data from randomized controlled trials. And that's what we'd like to address. But I'm aware that it's slightly more tricky with oseltamivir than with COVID treatments because there's clearly an established pattern of use in lots of settings. And in particular, there's guidance in the UK released by the UKHSA, which recommends using neuraminidase inhibitors in patients hospitalized with flu. And that's usually reflected in local antimicrobial guidelines as well. But although that's advice from the branch of the Department of Health, the Department of Health and the NIHR do support influenza trials that include a no antiviral arm. And this letter was released last year to support trials on the back of another letter the year before by the Chief Medical Officer. And I'm just going to quote from this briefly. So as per the Chief Medical Officer's letter from January 2023, we want to emphasise why, specifically for those hospitals and clinicians undertaking national trials, it's entirely in keeping with good clinical practice and our guidance to randomise. Then we therefore ask that every effort's made to enrol patients admitted to hospital with influenza into REMAP CAP or recovery. It provides the option to evaluate new antivirals like baloxavir, as well as existing treatments like oseltamivir, where there's uncertainty, and also the option of new treatments like steroids. But because oseltamivir use is often part of routine practice and is in routine guidelines, we would encourage local discussions to make sure that if people are randomizing, then other people that might be involved in writing the guidelines or have an opinion about treatment are also involved in that discussion. Because we know that in some cases, some people might want to just treat and wouldn't be happy with randomization. So I think this is something where there needs a bit more local discussion than with some other comparisons. And in terms of practicalities of oseltamivir in recovery, just a reminder that patients who've received or have planned use of a neuraminidase inhibitor are ineligible. And that's particularly relevant because if patients are coming into A&E and are receiving treatment very early, then that would make them ineligible for that part of recovery. And in which case, if patients, if clinicians and patients want to be involved in the trial, we need to make sure we try to discuss that with them as early as possible so that we can actually randomize people and learn something rather than just following sort of random practice. Again, just to mention that if patients have got a degree of bacterial co-infection, it doesn't make them ineligible, provided the clinical team think that flu is contributing to their lung disease and therefore that they might benefit from antiviral treatment. And another note just about oseltamivir supply, this will switch over to NHS stock in November. At the moment, we're supplying this via Roche UK directly to sites. But as part of the switchover of the baloxavir supply, we'll start using NHS stock, which will be hopefully a lot simpler for site teams. Then on to baloxavir, and I don't have as much to say about this, but this is a newer influenza antiviral with a distinct mechanism of action. It reduces viral load probably faster than neuraminidase inhibitors, so is appealing for a treatment of patients in hospital with severe disease, although it does seem to be more likely to have the development of resistance mutations arising on treatment. Because it's got a different mechanism of action, it may be more effective than neuraminidase inhibitors, and also the combination of both drugs might be better than either alone. And so with our factorial design, we should get information about both questions. And like oseltamivir, there's good evidence that it reduces the duration of symptoms in patients when it started very early with mild flu, but there really isn't any good evidence in hospitalized patients, and that's what we'd like to generate. In terms of its use and recovery, just like oseltamivir, if the patients receive treatment for their current illness or it's considered indicated, then they're ineligible, although this is much less likely because this drug isn't really used in routine practice very much. And also if patients have got a degree of bacterial co-infection, they're potentially eligible. And at the moment, we're supplying baloxavir from Roche UK, but this supply system will switch over in November to centrally supplied baloxavir. So there'll be no change in how baloxavir is used in the trial. And we'll contact site teams in the next few weeks to give them more information about that process. And then finally, corticosteroids for flu. We know with COVID-19 that corticosteroids reduce the death by about a fifth in hypoxic patients. And actually, steroids were proposed as a treatment for severe flu before COVID was ever on the scene, but they've never been properly tested. And by reducing immune-mediated lung damage, it may improve survival in severe flu, just the same way that it does in COVID. So this comparison is open to patients with flu pneumonia plus hypoxia. So they need to be on supplemental oxygen or have SATs of less than 92% on air. And that's because we know with COVID, the benefit was really limited to patients that were hypoxic. It's contraindicated if there's current or planned use of systemic corticosteroids, or if the patient's co-infected with SARS-CoV-2, because in that case, steroid treatment is likely to be indicated for their COVID. And most clinicians have got lots of experience of using corticosteroids in patients in hospital. And so we ask them to anticipate common side effects and manage those as they would in their normal practice. For example, hyperglycemia in patients with diabetes, patients at high risk of peptic ulceration, and also the risk of secondary infection with steroids. In terms of the flu comparisons, we're now open at a total of 51 sites in the UK and in the EU, and current recruitment is shown here. So baloxavir is currently winning with 280 participants in that comparison, 54 in the oseltamivir comparison, which may be lower because of the things I just mentioned about routine use, and 89 in the dexamethasone comparison. And obviously these numbers have been pretty much frozen since flu transmission ended in about February early this year. And then just a word about recovery and REMAP-CAP. You may have seen from our emails that we're collaborating with REMAP-CAP for the flu comparisons. REMAP-CAP's the other main UK trial that's was a platform trial looking at COVID treatments and is also looking at the same flu treatments as recovery. Because we're looking at the same questions, we've agreed to coordinate so that we can maximise the chance of producing clear answers. And that means that only one of the trials should be open in any particular clinical area at one time. So if a particular sort of hospital is doing REMAP-CAP, then we would want to, they should continue doing REMAP-CAP and shouldn't open recovery. If there were separate hospitals within a trust, only one of which was doing REMAP-CAP, it may be possible to open recovery at the other one, provided there was no plan to operate REMAP-CAP there. So our aim is for one of the trials to be open wherever inpatients are with influenza are cared for in the NHS. And as part of that collaboration as well, we'll be doing a combined analysis and primary publication so that all participants recruited to either trial will contribute to the final results. And although we're collaborating, it's worth just reminding sites that the trials remain separate. So we've got different protocols, slightly different eligibility, and slightly different follow-up procedures. So just make sure you're looking at the correct information, particularly if two trials were running in the same trust with the same team recruiting patients. But what we would say is that if there are any clinical areas where you're not planning to recruit in patients with flu to either trial, then please consider participating in the recovery flu comparisons. There's still time to set these up before flu transmission starts. Both REMAP Cap and Recovery are offering £400 per flu participant recruited to support trial sites with recruitment, because we know that shortage of site staff is a big problem at the moment. And also just a reminder that Recovery, Flu and CAP comparisons are both on the CRN non-commercial portfolio, or the RDN as I think it's now called. And the Recovery Flu comparisons are planned to continue until at least 2026. Okay, moving on to COVID, to community-acquired pneumonia, sorry. This is obviously a very common reason for hospital admission in the UK, and actually it's the fourth leading cause of death worldwide, estimated to kill over 2 million people per year. And in Recovery, for participants to be eligible for the CAP comparison, they have to have a diagnosis of CAP with planned antibiotic treatment. And as I mentioned before, they're ineligible if they have suspected or confirmed SARS-CoV-2, flu, pneumocystis pneumonia, or active pulmonary tuberculosis. But testing for these things isn't required for trial purposes, and is only required if it's being done as part of standard care. And in particular, it's worth mentioning that if patients are admitted to hospital with a respiratory illness during winter, then the chance of it being flu is quite high. So if somebody has an influenza test or a planned influenza test when they're admitted, and the result of that is still pending, then please don't recruit to the CAP comparison until we've got the result, because we don't want to recruit somebody that ends up having flu. In terms of the evidence for the corticosteroid comparison, I just wanted to highlight why we're looking at this, because I think it's a really important unanswered question. The idea of using steroids to improve outcomes in patients admitted with CAP has been around for a long time. Actually, the first randomized trial was back in the 1950s, and there've been about 20 randomized trials with sort of 3,000 or 4,000 patients in total, but still without a definitive answer. There have been over 20 meta-analyses of the same trials, but even as of last year, they're coming to differing conclusions. So I've just quoted two recent meta-analyses. On the top, Bergman et al. Concluded that the benefits, that there was a reduction in mortality with steroids, but in Salim et al., they found no association between corticosteroid therapy and mortality, treatment failure, or adverse events. So I think this really highlights that we haven't produced the kind of definitive answers that we did with COVID that can just inform clinical practice and allow us to move on to other questions. There is some evidence on non-mortality outcomes in steroids for the treatment of CAP. There's fairly good evidence that in things like clinical stability scores, including fever or CRP, it reduces the time to clinical stability, and also reduces the time to discharge in one trial. But the problem with this is that because steroids directly reduce fever and CRP, this may not be improving outcomes. This may just be, in effect, masking the inflammatory response and reassuring clinicians that they're working, whereas in fact, the chance of a bad outcome is unchanged. And in keeping with that, there's some signal of increased readmissions in patients that were treated with corticosteroids. And as long as uncertainty about the effect on sort of the main outcomes of pneumonia, there's also always the effect of concern about side effects with steroids. So hypoglycemia, GI bleeding, and secondary infection. And so steroids aren't really used very widely in routine practice for patients admitted with CAP. But it's a very promising question, and this just shows the forest plot from that top meta-analysis. And I should remind you that different meta-analyses seem to come up with different results, but I think this one includes most of the main trials of community-acquired pneumonia. And if you're not familiar with looking at this kind of forest plot, then each line is a separate trial that includes the number of patients admitted to that trial treated with steroids and the number dying versus those that had usual care or placebo. And in total, this meta-analysis reported results on just over 3,000 patients. And this was mostly patients with severe CAP, so those requiring sort of critical care. And in this meta-analysis, the total number dying treated with steroids was 104 versus 152 receiving usual care, which is highly conventionally significant, but so far hasn't led to a change in practice. And I think for lots of people, there's still substantial uncertainty as to whether steroids are of benefit, and if they are, who should receive them. You may be aware of two recent ICU trials that produced what have been reported as conflicting results that I've just highlighted here, and that's the Cape Cod trial and the ESCAPE trial. And so this is still very much a live area of debate. And actually, REMAP-CAP itself recently reported the headline results from their corticosteroid comparison, which stopped because they didn't think that there was a benefit of steroids, although I think we're still waiting for the full results of that. So I think what we really need is more patients randomized to produce clarity. And in terms of current guidance, I won't go through these in detail, but the top line is the American guidelines, which suggest not using steroids in CAP for patients admitted. NICE guidance recommend not using steroids unless there's another indication. And even the more recent European guidance recommend that steroids should only be used if shock is present. So steroids aren't being used at the moment, but there's quite some randomized evidence that really suggests that they could be of similar benefit to with COVID. And what we need is more patients randomized from a wide range of clinical backgrounds to inform treatment. Okay, in terms of the CAP corticosteroid comparison, there's no requirement for hypoxia, unlike the flu comparison, and that's partly because these previous trials haven't required hypoxia. And with bacterial pneumonia, the pathogenesis is somewhat different to viral pneumonia. And as with the other dexamethasone comparison, common side effects of steroids should be anticipated and managed as in normal practice. In terms of how we're doing with this comparison, it was introduced into the protocol early this year and is now open at about 30 sites, but recruitment is only really just getting going. Some sites have been recruiting very well, but we know lots are gearing up to start recruiting this winter, and CAP is probably about twice as common in winter as it is in midsummer. So hopefully we can recruit serious numbers over the next several months. The recruitment fee for this comparison is £100 per participant, and I really would encourage sites, if they're not participating, to consider doing so, because it's a simple comparison. There's no sampling. Dexamethasone is from NHS stock, and as with all the recovery comparisons, follow-up is fairly straightforward, and we make lots of use of routinely collected healthcare data. And just finally for CAP, I want to mention ASPECT, which is the other big community-acquired pneumonia trial. You may know about this already. This is looking at the effect of aspirin at reducing the risk of MI and stroke in patients that have been admitted with CAP, because there's quite a high risk in patients even after they're discharged of having these events. We know that's running in quite a few different trusts, and we know that lots of CAP patients will be eligible for just one trial, for example, if they're already on aspirin or steroids. But lots of patients will be eligible for both. And we've discussed recruitment with the ASPECT investigators, and we would encourage sites to take part in both trials if possible. We know that there's no conflict between the protocols, so eligible patients could be recruited into both trials. And even if they're not recruited into both trials simultaneously, it's likely to be quite efficient to be screening CAP admissions for both trials and then recruiting to one or other, depending on local priorities and which the patients are eligible for. So please consider opening recovery CAP dexamethasone comparison if you're open to ASPECT. And conversely, if you're not open to ASPECT but interested, then they're still opening new sites. So please contact the ASPECT team if you are interested. And finally, just a few slides on trial procedures. We know quite a few sites are opening new comparisons for the winter. The payment of the flu and CAP recruitment fees does require a simple amendment to be signed by the trust. It's only a few pages, so there isn't very much that's likely to be difficult to agree. But as always with these things, it can be a limiting factor. So if you're in the process of opening a new comparison and that isn't signed yet, please consider chasing it on your side. And if you're uncertain about the status of the amendment or anything else related to opening a new comparison, like training requirements, swab kits, or PI confirmation, then please do contact us as soon as possible on the main trial email address. In terms of sampling, I think I've mentioned this already, but no swabs are needed from patients in the flu comparison. That includes whether or not they're allocated active treatment. And then it consists of just 2 nose swabs, one taken at baseline, which is day 1, and that should be taken after consent before randomization. And then a second swab is taken at day 5. And we don't require any blood samples from anyone anymore. And if you run out of swab kits, then please email the trial team, or ideally before you run out, and then we can supply some more. And then just as a reminder, there's no biological sampling from patients in the CAP comparison, and there are full instructions for sampling on the trial website. And then consent monitoring. For some time, we've been asking a scanned copy of the consent form to be emailed to the recovery trial team within 72 hours for every recruited participant. Just a reminder, if you could write your name clearly on the form if you're taking consent, so we can make sure that those who are doing so have done the right training. And this should be sent to our NHS Net email address rather than the main trial email address for confidentiality reasons. But our main trial address has actually just changed, or is in the process of changing. So we'll put the new trial address on our website in the next couple of days. And also see the recovery website for instructions on how to email the trial team. And then finally, I think just a word about completion of follow-up. So we'll send weekly reminders highlighting any people who've gone more than 28 days without a completed follow-up form. Completeness of follow-up has always been a strength in recovery and is one of the things that's really crucial to getting reliable results. So please do keep this up, especially as recruitment picks up this winter. And then finally, thank you. The recovery collaboration has been a huge success in terms of understanding COVID treatment better and influencing global practice. And we hope that we can produce similar practice-changing evidence for the management of flu and CAP. The flu season is unpredictable and is usually quite brief, so it's essential that teams are prepared to start recruiting as soon as it arrives. And also we know that many of you won't have worked on recovery before, so please just do get in touch with the trial team if you have any questions about any trial procedures. And lastly, thank you for being part of the recovery collaboration. Okay, so we'll just move over and see if there are any questions that have come in. I can't see that anybody's put any questions up so far. So if you have any questions, please add them to the Q&A now. In terms of questions that came up yesterday, and I think one of the main things was about the changeover of IMP supply. So we'll be updating site teams and pharmacy contacts about the change to the supply arrangements in the next couple of weeks, and also giving sites instructions as to how to stock up on baloxavir, hopefully in good time for any flu transmission. Okay, I can't see any questions coming in. In that case, if you have any questions that come up later, then just email us at the recovery trial address and we can get back to you. Otherwise, I might just hand over to Richard Haynes, who's joined us, to maybe sum up and close things.
Thanks, Leon, and thanks everybody for coming. I'm afraid you've got me rather than Peter Horby, who is currently in Rwanda helping with the Marburg virus outbreak there, which you might have heard about. There is one question that's just popped up, Leon, which I think I can do, which is asking about blood samples for influenza patients. You're correct, we don't need any blood samples for those patients, just a nasal swab for them. I'm saying that. Leon, correct me if I've got that wrong.
That's right.
In terms of otherwise wrapping up, yeah, thank you for your support for recovery over the years. The COVID comparisons were very quick, and we managed to recruit very rapidly for those and get answers which change practice, not just in the UK but around the world. I think we'll be able to do the same with these comparisons. I think recruitment will be slower, but that doesn't mean that the answers will be any less important, and probably actually all the sweeter when they do come. So please do ask us any questions that you've got, and we'll be happy to answer them. If in Edinburgh you're having difficulty getting people to support the community-acquired pneumonia arm, would be very happy to talk to your clinical teams there, if that would be helpful to explain the potential benefits but the existing uncertainty. So just drop us a line if we can help. But otherwise, thank you very much indeed for coming on this afternoon, and for your ongoing support.
Thanks, everyone. Bye-bye.